So again, we were discussing a right bundle branch block, and to diagnose right bundle branch block, you need to look at two leads which are V1 and V6. In V1, there will be RSR pattern or kind of M-shaped QRS complexes. What is RSR pattern? RSR pattern is there is a small R wave, then there is an S wave, and then there will be a large R wave. So the first R wave is called R wave, and the second, the larger one is called R dash. So there will be RSR dash pattern in V1. While in left bundle branch block, there is a deep inverted QRS complex in V1 in case of left bundle branch block. Now let's look at lead V6. In left bundle branch block in lead V6, there was an M-shaped broad QRS complex. While in right bundle branch block, you look at this wave. This is R wave and this is S wave. There is a wide and slurred S wave. You can see a notching in the S wave. This is called slurring of the S wave. So RSR pattern in V1 and wide and slurred S wave in V6. These 2 points will make the diagnosis of right bundle branch block. For your simplicity, you can only or you can simply remember just this one point, that is RSR pattern in V1. RSR pattern in V1 will make the diagnosis of right bundle branch block. For Plab 1 exam, left bundle branch block is important. So remember both the criteria for left bundle branch block. For left bundle branch block, W-shaped QRS complex in V1 and broad and M-shaped QRS complex in lateral leads such as 1 AVL and V6. Is this a point clear to everyone?
Dr. Shah, can you please explain me the slurred S wave you were talking about earlier?
Yes, sure. So for right bundle branch block in V1, there will be RSR pattern, and in V6, you can see that this is R wave. The first positive wave is R wave, and the first negative wave is S wave. So this S wave is wide, and you can see the notching. Can you see the notching? Just look at
Yes,
the follow the cursor. Can you see this notching?
yes.
So this is slurring of S wave.
What do you mean by RSR pattern?
RSR pattern is, as I told you, that the first positive wave is R wave, and the first negative wave is S wave. So you can see RSR pattern in V1. This is R wave, right? This first, the smaller one, the first positive wave is R wave, and then this is S wave, and then again there is another R wave. Is that right, Dr. Asma?
Yes.
So this is called RSR pattern, which is a specific feature of right bundle branch block. Is it clear now?
Yes, it's clear. Thank you.
Anyone else has any confusion? Okay, so this was all about left bundle branch block and right bundle branch block. Left bundle branch block is new left bundle branch block is equal to ST elevation MI. So the management will be same as ST elevation MI. Now our next topic is ventricular ectopics or premature ventricular contraction or extrasystole. They are all on the same name for ventricular ectopics. So far we have discussed that broad complexes, if they are regular and with tachycardia, then it will be ventricular tachycardia. Polymorphic broad complexes, torsade depointes, and broad complexes in V1, V6, 1 and AVL, left bundle branch block, broad QRS complex with RS pattern in V1, right bundle branch block. Again, ventricular ectopics also produce broad QRS complex on ECG. So basically, all of these is all of these topics are related to broad QRS complex on ECG. So now we will discuss some points how to identify premature ventricular contraction, extrasystoles, or ventricular ectopic on ECG. Remember again 2 points or 3 points to identify premature ventricular contraction on ECG. A premature ventricular contraction is a premature beat. Premature means a beat that originates or that arises before its time. A beat that originates before its time. So this is 1 point for identification of ventricular ectopic. The second point is that the QRS complex of the premature ventricular contraction will be broad. And this broad QRS complex, a QRS complex that is more than 20 milliseconds segment and T wave changes. Remember that if the QRS complex is positive, then the discordant ST segment and T wave changes mean they will be opposite to QRS complex. If the QRS complex is upward or upright, then ST segment and T waves will be downward or inverted. So if the QRS complex is positive, then there will be ST segment depression and T wave inversion. And if the QRS complex is negative, then there will be ST segment elevation and hyperacute T wave. Let me show you an example. Then you. So this is a diagram of a premature ventricular contraction. See, this is a broad QRS that is followed by a depressed ST segment and an inverted T wave. So this is a premature ventricular contraction or premature ventricular beat. The diagnostic criteria or the identification point for premature ventricular contraction is a broad QRS complex that is followed by discordant ST segment and T wave changes. Now, in this diagram, you can see that the QRS complex is positive and the ST segment and T wave, there is ST segment depression and T wave inversion. Now, let me give you an example of a negative QRS complex. So look at this premature ventricular beat. In this, the QRS complex is downward and and the ST segments and T waves are upward. So the discordant ST segment and T wave changes are ST segment elevation. You can see that this is the baseline and the ST segment is elevated from the baseline. So after a negative QRS complex, a negative broad QRS complex, the ST segments is elevated and also the T wave is hyperacute. You can see that if this is the baseline, then this T segment is elevated from the baseline. Is this point clear to everyone? I'll repeat it again.
Can you repeat, please?
Yes.
Yeah, same here. Please repeat it.
First of all, remember the criteria for ventricular ectopic. The criteria for ventricular ectopic is broad QRS complex followed by discordant ST segment and T wave changes. Discordant ST segment and T wave changes means the ST segment and T wave changes will be opposite to the QRS complex. If the QRS complex is downward, then ST segment and T wave will be upward. Similarly, if the QRS complex is upward, then the ST segments and T wave will be downward. As an example, let show you this. And the ST segment, you can see that this blue line is the baseline and the ST segment is depressed. And also T wave is inverted or there is T wave inversion.
Doc, I don't think
Similarly,
I see the diagram.
just a minute. Can you see it now?
Yes.
So look at this QRS complex. This is upward, and the and the T wave and the ST segment that is after this QRS complex, they are depressed or they are downward. This is the blue line is the baseline, and you can see that this ST segment is depressed and the T wave is inverted. So broad QRS complex with discordant ST segment or T wave changes, it makes the diagnosis of a premature ventricular beat. Similarly, another example, in this example, you can see that QRS complex is downward or it is negative, and the ST segments and T wave, they are elevated.
Yes, it is.
Yes, it's clear.
So ventricular ectapic, uh, remember that this topic will not be tested that much in Plab 1 exam. I'm just telling you this for your knowledge. You just need to know that what is ventricular ectopic or premature ventricular contraction. Premature ventricular contraction is a ventricular contraction that is before its time. And the criteria for premature ventricular contraction is it is very less likely that they are going to ask you or they are going to ask you to identify premature ventricular contraction on ECG in a Plab 1 exam. So premature ventricular contraction can be unifocal, they can be multifocal. If the shape of all the premature ventricular contraction is same, then they will be known as unifocal PVCs. And if their shapes is different, then they will be known as multifocal PVCs. What is bigeminy, trigeminy, quadrigeminy? They are simple terms. Bigeminy means every second beat is a PVC. Let me show you an example. Now this is an ECG of premature ventricular contraction or ventricular by Gemini. You can see that this QRS complex is normal and this QRS complex is broad, followed by discordant ST segment or T wave changes. This is a broad QRS complex followed by ST segment depression and T wave inversion. So one normal beat, one premature beat, again one normal beat and one premature beat, one normal beat, one premature beat. This phenomena is known as ventricular by Gemini. And if every third QRS complex is a premature, every third beat is a premature beat, then it will be known as trigemini. If every fourth is beat is a PVC, then it will be known as quadrigemini. And if there are two consecutive PVCs, then it will be known as couplet. And if there are 3 or 30 consecutive PVC, 3 or 30 consecutive PVCs, then it will be known as non-sustained ventricular tachycardia. So PVCs can be dangerous. If there are more than 30 consecutive PVCs, then it will develop into ventricular tachycardia, which can be dangerous. So less than 30 consecutive PVC, they are known as non-sustained ventricular tachycardia. In this diagram, you can see that this is a premature ventricular contraction because the QRS complex is broad and there is discordant SC segment or T wave changes with an upright T wave. In this diagram, again, you can see that broad QRS complex followed by discordant ST segment and T wave changes. The cause of premature ventricular contraction include ischemic heart disease. In normal population, they are not harmful because they can be caused by stress, alcohol, caffeine, medication, cocaine, amphetamines, etc. So they usually does not require any treatment. But in some cases or in old patient, premature ventricular contractions uh, signifies the underlying ischemic heart disease or cardiomyopathy. So they need to be investigated in old age patients. So this was a short description about premature ventricular contraction. Now our next topic is Wolff-Parkinson-White syndrome. What is Wolff-Parkinson-White syndrome? Normally, we know that an impulse is generated in the SA node and then it travels through atrial muscles to AV node, and from AV node then it travels to the ventricular muscles. So impulse start from the SA node and then it depolarizes the atrial muscles, which is represented on ECG by P wave, and then the impulse stays in the AV node for about 0.2 seconds. On ECG, this pause or this stay is represented by PR interval, and then it depolarizes the ventricular muscles, which are represented by the QRS complexes on ECG. In what happens in Wolff-Parkinson-White syndrome? In Wolff-Parkinson-White syndrome, there is an accessory pathway that exists between the atria and the ventricular muscles. So the impulse travels faster through that accessory pathway to the ventricular muscles. So what will happen on the ECG? Instead of a normal PR interval, PR interval means the stay of the impulse in the AV node. As the impulse is not staying in the AV node for the duration of time of 0.2 seconds, but it is traveling to the ventricles through an accessory pathway. So it will result in pre-excitation of the ventricular muscles, which will result an upward slant of PR segment or PR interval in an ECG. So the upward slant you can see in this diagram. Here the PR interval is straight, but here the PR interval is forming a slope. So this slope of PR interval is known as a delta wave. So the ECG finding for the diagnosis of Wolff-Parkinson-White syndrome is delta wave. Delta wave on ECG, if in the Plab 1 exam they mention that a person present to you with palpitation and there is delta wave on ECG, then it will make the diagnosis of Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome is basically a congenital disorder, and this accessory pathway can result in atrial fibrillation, atrial flutter, and other types of arrhythmias as well. That's why Wolff-Parkinson-White syndrome is dangerous. An example of ECG of Wolff-Parkinson-White syndrome, you can see that in ECG that there is a slant or there is a slope of PR interval here, 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 and here, and here. In all the QRS complexes, the PR segment is forming a slope with QRS complexes. So it makes the diagnosis of Wolff-Parkinson-White syndrome. The PR interval is usually less than 120 milliseconds. Delta waves are present on ECG, and QRS is prolonged because of this upward slant of PR interval. The QRS is prolonged. So this was all about Wolff-Parkinson-White syndrome. The main point that you need to remember about Wolff-Parkinson-White syndrome is that presence of short PR interval and delta waves on ECG. So this was all about different kinds of arrhythmias and their management. Is it clear to everyone up to this point? If anyone have any question, and then they can ask.
Do
No
we have to
question?
remember these PR and QRS, these 120 milliseconds and 110 milliseconds?
Yes, you need to remember that because it is required to make a diagnosis of left bundle branch block and for ventricular tachycardia and for supraventricular tachycardia as well.
Okay.
The normal PR interval, just remember the normal PR interval is 200 millisecond or 0.2 second, and the normal QRS complex is 120 milliseconds or 3 small boxes. Just remember these 2 or 3 things.
Okay, thank you.
Because left bundle branch block is often tested in the Plab 1 exam. So that's why it's important to remember to make a correct diagnosis. Sometimes they will give you an ECG in the exam because in the previous exam, in the November attempt, there was 2 questions in which ECG was given. And sometimes it's difficult to make a diagnosis just on the basis of history that is given in the question. So our next topic is hypertension management. Hypertension classification, there are three stages of hypertension: stage 1 hypertension, stage 2 hypertension, and stage 3 hypertension. Stage 1 hypertension is clinic BP of 140 over 90. Stage 2 is clinic BP of 160 over 100. And stage 3 is clinic BP of more than 180. So simple, the clinic blood pressure of more than 180 is stage 3 hypertension. Stage 1 and stage 2, clinic BP of 140 and 160, and home blood pressure or HbPM of 135 over 85 is stage 1, and 150 by 95 is stage 2. It's important to remember the stages of hypertension uh, because the management of different stages of hypertension is different. Remember that stage 1 hypertension in patients without any other comorbidities does not require any treatment. Only lifestyle advice will be given to the patients with stage 1 hypertension unless we will only treat stage 1 hypertension if the patient has target organ damage, established cardiovascular disease, renal disease, diabetes, or a 10-year cardiovascular risk of more than 20%. So stage 1 hypertension does not require any treatment unless the patient has some other diseases such as cardiovascular disease, renal disease, diabetes, or a cardiovascular risk of more than 20%. In only these cases, we will treat a stage 1 hypertension. Otherwise, only lifestyle advice will be given, such as low salt diet, caffeine, reduce caffeine intake, uh, stop smoking, drink less alcohol, eat a balanced diet consisting of fruit and vegetables, exercise more, and lose weight. These advices will be given to a patient with stage 1 hypertension. Stage 2 and stage 3 hypertension, what is how we are going to manage stage 2 and stage 3 hypertension. If a patient present to you with stage 2 hypertension with a clinic BP of 160 over 100 before starting any treatment, uh, you need to record the ambulatory blood pressure or home blood pressure before commencing any treatment. So if a patient present to you at the clinic and his blood pressure is 160 over 100 and they ask you about the next best step in the management, then your answer will be uh, home blood pressure or ambulatory blood pressure recording. And after that, you will start the antihypertensive treatment. Now, what is the stepwise management of hypertension? If the patient is less than 55 years old, remember that patients who are old or who are above 55 years of age, their arteries are hard. So in patients who are old or who are above 55 years of age, because their arteries are hard, so we need to give something that will relax the smooth muscles in their arteries. So in patient below 55 years of age, we'll start with ACE inhibitors or ARBs because they show a good response to ACE inhibitors or ARBs. And in the patient who are above 55 years of age, in those patients will start calcium channel blocker, amlodipine or nifedipine. So the first step is ACE inhibitor in young patients less than 55 years of age and calcium channel blocker in more than 55 years of age or in older adults. Now, Afro-Caribbean, remember that Afro-Caribbean of any age present to you, you will not start an Afro-Caribbean with an age of 40 years. You will not start him on ACE inhibitors or ARBs because Afro-Caribbean they metabolize the ACE inhibitors or ARBs very rapidly. So their effect is decreased. That's why the first choice drug or the first line drug for the management of hypertension of Afro-Caribbean of any age will be calcium channel blockers. And a patient of diabetes of any age, there are two circumstances in which you will ignore the age barrier. One is Afro-Caribbean. Afro-Caribbean of any age, the first line drug is calcium channel blocker. And diabetic of any age, the first line drug is ACE inhibitor. Because ACE inhibitors or ARBs are renoprotective, they have a beneficial effect on proteinuria. So that's why diabetic of any age, the first line drug will be ACE inhibitors for the management of hypertension. And Afro-Caribbean of any age, the first line drug will be calcium channel blockers. While on the other hand, in all other age or in all other patients, if the age is less than 55, we will start with ACE inhibitor. If more than 55, we will start with calcium channel blocker. So this was the first step medication. Now, if the blood pressure is not controlled or our target blood pressure is not achieved with step 1, then we will move towards step 2. So in step 1, if we started ACE inhibitors, then in step 2, we will add calcium channel blocker. And if in step 1, we started calcium channel blockers, in step 2, we will add ACE inhibitor. So in step 2, the second drug is added, either ACE inhibitor or calcium channel blocker. Now, third step.
Can you say that? Step 2.
Step 2 is that in the if we started ACE inhibitors, then in the second we will add calcium channel blocker. And if we started calcium channel blocker in the first step, then we will add ACE inhibitor.
Okay.
In simple words, in the first step, in the first 2 steps, ACE inhibitor and calcium channel blockers are used, depending upon the circumstances. Now, the third step, if still with 2 drugs, the target blood pressure is not achieved, then we'll add a third drug, and that is thiazide diuretic. Thiazide and diuretics are currently recommended by the NICE in the management of hypertension, and they chlorthalidone and indapamide. Previously, hydrochlorothiazides were used, but it is no longer recommended. The recommended thiazide diuretics for the management of hypertension is chlorthalidone, either 12.5 milligram or 25 milligram once daily, or indapamide, 1.5 milligram or 2.5 milligram once daily. So if target blood pressure is not achieved with 3 medication, then we will add a 4th medication. Now in the 4th step, we have 2 options, either to increase the dose of thiazide diuretic or to add a aldosterone antagonist, spironolactone. But we all know that spironolactone causes hyperkalemia. So before adding spironolactone, we will check the patient's potassium level. If patient potassium level is less than 4.5, then we'll add an aldosterone antagonist such as spironolactone. But if patient's potassium level are more than 4.5, then we'll add then we'll increase the dose of thiazide diuretic. So the fourth step depends on the potassium level. If potassium level less than 4.5, then we'll add spironolactone. And if potassium level are more than 4.5, because spironolactone can cause hyperkalemia, so we will increase the dose of thiazide diuretics if the potassium level are more than 4.5. Now, if the patient failed to respond to 4 drugs or to step 4 measures, then he should be referred to a specialist. So if the target blood pressure is not achieved with 4 drugs and they ask you about the next best step in the management of this patient, then you will choose seek expert advice or refer to a specialist. So what are the blood pressure targets in different patients? For diabetic patients with end organ damage, the target blood pressure is less than 130/80. So in diabetic patient, the target blood pressure is 130/80, less than 130/80 if end organ damage is present, such as renal disease or retinopathy are present, then our target blood pressure will be less than 130/80. And if no target end organ damage present, then less than 140/80 will be our target blood pressure. And patient without diabetes mellitus, their target blood pressure is, if the age of the patient is less than 80 years, then the target blood pressure is 140/90, less than 140/90. And if the patient is above 80 years, then the target blood pressure is 150/90. So this was all about the management of hypertension. I hope it's clear to everyone. Is there any question anyone want to ask? So as we have discussed before that the first line drug to treat hypertension in diabetics of any age is ACE inhibitors. But remember that there's a contraindication of ACE inhibitors and ARB